1. Anesthesia monitoring standards. 2. Local and regional anesthesia. 3. General anesthesia and MAC. 4. Neuromuscular blockade and airway. 5. Complications and emergencies. And finally, 6. Postoperative analgesia. Let's go.
Section 1. Anesthesia monitoring standards.
Okay, so these minimum monitoring standards, they are absolutely non-negotiable across the board. We're talking continuous evaluation of oxygenation, ventilation, circulation, and temperature. But here's a massive takeaway for you. When it comes to ventilation, if you have an endotracheal tube or an LMA in place, continuous end-tidal CO2 analysis isn't just a nice-to-have, it is literally an absolute requirement to confirm that the airway is secure.
Section 2, Local and Regional Anesthesia. I absolutely love this trick for the boards. It's called the rule of eyes. Who knew spelling could actually save you in a clinical scenario, right? Basically, to distinguish an ester from an amide, just look at the drug's name. Amino esters, like procaine or tetracaine, only have one eye. Amino amides, like lidocaine or bupicaine, have two eyes. It's a brilliantly simple shortcut, so definitely lock that one in.
Now, knowing your exact agent really matters here. The major red flag that should jump out at you is bupivacaine. It has an incredibly low maximum dose, just 2.5 milligrams per kilogram plain. And the reason this is so critical, unlike other local anesthetics that usually warn you with CNS toxicity first, an accidental intravascular injection of bupivacaine can trigger immediate, severe cardiovascular collapse. So extreme caution there.
Moving into neuroaxial blockade, you have got to know the difference between a spinal and an epidural. A spinal goes deep into the subarachnoid space. It's fast, and the sensory level is actually driven by the drug's baricity, meaning, its density compared to spinal fluid, along with the patient's position. Epidurals, on the other hand, stop short in the epidural space. They have a slower onset, and their block level is driven by the volume of the injection. Plus, an epidural catheter lets you redose, which is super handy.
But listen, spinals aren't for everyone. There are some absolute hard-stop contraindications you have to memorize. Lack of consent, localized infection at the puncture site, increased intracranial pressure, generalized sepsis, and coagulopathy. If any of those are present, a spinal is completely off the table. No exceptions.
For upper extremity peripheral nerve blocks, there's a vital exam distinction between the interscalene and infraclavicular approaches. Interscalene targets the trunks, which is great for shoulders, but it almost always blocks the phrenic nerve. So if your patient has severe pulmonary disease, you want the infraclavicular block. It's the safer route because it targets the cords, covers the arm and hand, and crucially, it spares that phrenic nerve.
Section 3, General Anesthesia and MAC.
Let's unpack some common monitored anesthesia care agents, because there are some fascinating caveats here. Dexmedetomidine, watch out for bradycardia. Midazolam gives you amnesia but absolutely zero analgesia. Propofol is incredibly fast, but it triggers a hypotensive drop because it decreases vascular resistance. And then there's ketamine. Ketamine is a brilliant analgesic, but it notoriously causes emergence delirium. So the standard protocol is to co-administer it with a benzo like midazolam just to blunt those hallucinatory reactions.
Escalating to general anesthesia, your choice of IV induction agent depends entirely on your patient's comorbidities. Active coronary ischemia? You have to use extreme caution with propofol. If you need cardiovascular stability, etomidate is usually preferred, though you do have to watch for adrenal insufficiency. Now, what if they have severe asthma? Ketamine is your go-to because it bronchodilates and increases cardiac output. But, and this is a big but, because it raises intracranial pressure, ketamine is strictly contraindicated in head trauma.
Section 4, Neuromuscular Blockade and Airway.
The differences between paralytics are wild and highly testable. Succinylcholine is the only depolarizing agent we use clinically. It acts lightning fast, like in 60 seconds, but it carries massive risks. We're talking hyperkalemia and triggering malignant hyperthermia. Because of that hyperkalemia risk, it's an absolute no-go for severe burns or major trauma patients. On the non-depolarizing side, remember that atracurium can cause histamine release, while rocuronium gives you an intermediate duration without those crazy depolarizing risks.
To reverse this blockade, we use acetylcholinesterase inhibitors like neostigmine, but you must co-administer them with an anticholinergic like atropine to block the severe parasympathetic side effects. Now, here is the most critical takeaway for this entire section. The diaphragm is actually less sensitive to muscle relaxants than the head and neck. That means a patient might be breathing spontaneously, but still lack protective airway reflexes. That's exactly why recovery has to be confirmed with a train of 4 monitors monitor or a 5-second sustained head lift before you even think about extubation.
Tracking the airway escalation algorithm, we move from basic mask ventilation to a supraglottic device, like an LMA. I really want to emphasize this point. An LMA does not definitively protect the airway from aspiration. Because of that, it is contraindicated in non-fasted or morbidly obese patients. If you truly need to protect against aspiration, you have to escalate to endotracheal intubation, utilizing rapid sequence intubation, or RSI, for those emergent high-risk scenarios.
Section 5, Complications and Emergencies. These are your highest yield crisis protocols. Let's start with local anesthetic systemic toxicity, or LAST. If a patient seizes and collapses after a nerve block, step 1 is airway support and 100% oxygen. Step 2, suppress those seizures with benzodiazepines. Definitely avoid propofol if they're cardiovascularly unstable. Step 3 is modified ACLS, meaning avoid vasopressin and calcium channel blockers. And keep your epinephrine very low. Finally, step 4 is the silver bullet. Administer 20% lipid emulsion therapy as a 1.5 milliliter per kilogram bolus.
Then we have malignant hyperthermia, tachycardia, rigidity, hypercapnia, and soaring temperatures triggered by volatile gases or succinylcholine. The protocol here is extremely strict. 1. Immediately cease all triggering agents. 2. Administer IV dantrolene. 3. Monitor and treat the resulting hyperkalemia and acidosis. And 4. That patient needs mandatory ICU monitoring for 48 to 72 hours just to watch for any recurrence.
Let's rapidly hit a few other general anesthesia complications. Intraoperative awareness is a major risk with TIVA and neuromuscular blockers. If you're dealing with delayed emergence, systematically rule out hypoxia, hypoglycemia, and hypothermia. If you hit laryngospasm or those vocal cords forcefully snap shut, treat it aggressively with positive pressure mask ventilation. If that doesn't break it, push succinylcholine. And for postoperative nausea and vomiting, you treat with ondansetron, but use dexamethasone for prophylaxis.
Section 6, Postoperative Analgesia.
Opioids like fentanyl, morphine, and hydromorphone are obviously the workhorses for post-op pain control, but we need to zero in on the single greatest hazard here: oversedation leading directly to respiratory depression and apnea. That is your absolute biggest risk in the surgical population. So what do you do if a post-op patient is unarousable but spontaneously breathing? The rescue protocol is highly specific. First, give supplemental oxygen. Second, push IV naloxone, 0.04 milligrams, repeated every 30 to 60 seconds. But listen, don't just slam the naloxone. Pushing excess naloxone too fast can completely backfire, triggering severe pain, hypertension, and even flash pulmonary edema. Once they're awake, confirm adequate ventilation with an ABG, stop their opioids, and monitor them continuously. Remember, naloxone can wear off way before those long-acting opioids do. We're going to wrap up this explainer with a high-yield scenario to tie it all together. Minutes after receiving anesthesia induction with sevoflurane and succinylcholine, a 23-year-old male develops a temperature of 39.2 degrees Celsius, a heart rate of 148, blood pressure of 186/104, and muscle rigidity. What is the most appropriate first step in management? Well, based on the crisis protocols we just unpacked, I bet you know exactly what medication to call for. Keep reviewing these concepts, and thanks for joining us for this explainer. We'll catch you next time.